Hello, everybody. Thank you for having me here at SOCRA. I've spoken at a lot of the some of the regional events here in Arkansas, and I really am honored to be speaking at the national conference. The point, as you can see from the title here, is to kind of get us out of that thinking of only compliance and getting into thinking about, how do we better connect with participants. And so before I get started into that, here are my, financial interests to disclose. I'm on the FDA's Risk Communication Advisory Committee, and I'm a professor at the ULR Bowen School of Law and at the UAMS Translational Research Institute. So when you think of laws and regulations for health research and practice, which of these best fits your view? They're just another obstacle to comply with that inhibits innovation. You may not think this, but I'm sure you can think of somebody who thinks that. Or they provide an opportunity to better connect with patients and participants, depending on if we're in the clinical world or the research world. Now, of course, it's not just one or the other. These are not mutually exclusive. So that's kind of my motto is connecting while complying, and hence the title of this particular session. So how can we do both of these? Instead of making it an or, make it an and. And that's really what I want to talk a lot about today, kind of weaving in the kind of the regulatory trend, and then talking about kind of the compliance. So really, this is a shift of perspective. I saw this cartoon and I thought, oh, this is a great one. Because, if you're on a desert island and you're stranded and you see a boat, you get excited. But if you're stranded in a boat and you see some land, you also get excited. So it really is all about perspective. And that's when I think about compliance, there's so many people, maybe not us who are in compliance, every day, but the folks that have to comply and don't want to comply and want to do whatever it is that they're doing, research or, treatment of patients or whatever, they tend to kind of get exacerbated by, by all of the demands. So what we're going to talk about today, why clear communication matters in clinical research, the trend towards clear communication in clinical research, and then, how this all came to a head and is impacting our lives with the revised Common Rule, among other things, of course. So why does clear communication matter? And probably most of you have kind of get that general understanding about why it matters. But let me kind of dive into a little bit of, some of the things that I like to highlight that can help you make the case, to others in your institutions or your IRBs or wherever you're situated. So one of the things I always start with is this question, which of the following is the best predictor of an individual's health status? And in fact, these can all be predictors, of course, but literacy skills, tend to win out. So this is not even new data. This is data that was in the American Medical Association's a manual for clinicians almost 17 years ago. So we've known that this has been a problem for a long time, and that's probably part of the reason that we eventually kind of moved on from the Common Rule to the revised Common Rule. But it's much broader than that, as I'll talk about here today. So if you think about literacy levels among adults, now this is from the most recent major study about literacy. And you can see the title of it at the bottom of the picture there. It's called the PAC, so the Program for the International Assessment of Adult Competencies. And this is an international study, but breaking out the U.S. literacy component of it, you can see that, when you add that up, you're about 52% of folks fall into that either non-literate, below basic, or basic literacy levels. And I'll tell you what that means here on the next slide, how they categorize those folks. And then again, the other 48% are kind of in that intermediate and proficient level. So that's, no matter how you slice that, there's a big portion of people that struggle to understand, kind of the things that we put in front of them. So what do these categories mean? And you'll see the percentages are a little different here because this data comes from the major US study, which happened in 2003, I believe. It's 2002 or 3. I should have had the site on here. But that is called the National Assessment of Adult Literacy, and very correlated, but from a category perspective, you can see these aren't just, you attain the 4th grade reading level or something like that. These are skills that you're able to do. So below basic is identify how often to have a medical test based on info and clearly written pamphlet. Give 2 reasons a person with no symptoms of a specific disease should be tested for the disease. Intermediate, find the age range for a child to receive a vaccine. And proficient, find information to define a medical term by searching through a complex document. If you think about just what we're going through in life right now, with this COVID crisis, every single one of those things is touches somebody's lives, so it's not something that we don't ask, people who we know have low literacy skills to do proficient things. We ask them that all the time. And think about the vaccine, and finding an age range for a child to receive a vaccine. That's going to be happening how often as soon as we get this, not only with the flu vaccines, but with potentially the COVID vaccine. So we're asking people to go in and out of these categories all the time when we know they don't have the skills. And if you think about who's at risk, it can be anybody, of course, but people who are more at risk than others, are, older adults, 3 times more likely, Hispanic, Latino, 4 times more likely, people with poor health, 5 times more likely. And this is from an infographic from my friends at Communicate Health. But you can see that, it's kind of this vicious cycle. People with poor health are more likely to have, below basic or basic health literacy skills than people in good health. So how do you get people out of that cycle? And a lot of that is communicating, obviously communicating with them and getting out of our own comfort zone and getting into their views. Now, from a public health perspective, this is the health literacy rates from my home state of Arkansas. And you'll see on the right side, it kind of looks like a reverse L or like a hockey stick of some sort. That is the Delta region, and so these are, the darker it is, the higher prevalence of low health literacy. But if I were to overlay this with mortality rates, income, any other type of public health statistic, it would look a lot like this. And that is really the problem. And so, that's one of the things I often say is, though, even though we know certain, groups might struggle more than others, it's really a universal precautions approach for health communication is the best way to go, unless, of course, that person's abilities, right? If you don't know the person's abilities, you have to you can't assume that they can understand things. So particularly in our research world, because that's so foreign to most people, using clear communication strategies with everyone is just, it just makes a lot of sense. And so again, if you need a case study, we're living it right now. The COVID-19 is the case study of all case studies, no matter what you want to learn from it, how people, work, how people relate to working from home, to everything else. We've got the case study because everybody on earth has had to learn about it since the beginning of this year. So you think about health literacy, just because somebody has an engineering degree doesn't necessarily mean that they understand how COVID-19 works. And, I've talked to many healthcare providers that think this is a lot like the flu, and that's frustrating, right? It's frustrating probably for you, and it's frustrating for me. But so this is, we're living the time that's a great case study. So now, kind of moving on to some of the research that supports all of this. Now, this again from a clinical care study. Back in the 90s, one of the first studies that really looked at health literacy using patients from 2 public hospitals. found that people didn't understand the rights and responsibilities section of a Medicaid application. And then 60% didn't understand a standard informed consent form. Now, in the research world, we are well above a standard informed consent form, as we all know. So the typical research consent document is written at a high grade level. So if we equate grade levels with reading, as you may all be familiar with, 12th grade is senior in the US and 13th grade would be freshman in college. Historically, our consent forms have been written in that level, but we know, at least from a readability standpoint, if we were to put a grade level on the population's reading level, it's in that 6th, 7th, 8th grade level, depending on the study. So we know there's that disconnect there. So what are we going to do about it? That's kind of what the common rule was meant to deal with, but there's plenty of other things. So guess the reading level needed to understand this. This I took from a ct.gov consent form, and it's one long run-on sentence. I would try and read it for you, but I can't do it in one breath. So if you run this through a readability calculator, it's a little hard to read. So you can see that, ooh, that's probably a bit too complicated. It's at the 26th grade level. Now, I use this kind of for a couple of reasons. Now, one, just to show that that's too difficult for people to understand, but two, to show you that, that these readability scores are not all they're cracked up to be. We could understand this. And many of us have not gone through the 26th grade level. I certainly haven't. And I could write this and understand that. So that's what I don't really like about readability test scores, is that they, at the margins, when we get too far, like to the 20s, or we get down to the 5th or 6th, it becomes kind of a gaming the system. How does a readability scores work? And then I can manipulate it. So what I like to use them for is just to know if it's too difficult and am I going in the right direction. But once we start getting nuanced, you're like, oh, it's a 7.2 grade level instead of a 6.5, and our standards say what needs to be under a 6th grade level. That's missing the point of readability scores. They don't equate to understanding. So readability scores, depending on the readability measure, but they tend to focus on, sentence length, number of syllables and number of syllables in words. So let's say I created a sentence that had 75 words, but they were all easy words, but they had a lot of syllables. Like my daughter's name is Olivia, so 4 syllables. That would violate some of the readability scores because it's more than 2-syllable words. Ohio, 3-syllable words, but nobody has a problem with Ohio in terms of too long or something like that. So readability scores don't equate to understanding. They just kind of help you know if you're going in the right direction. And too often I think we just use that as we need some metric. We're evidence-based medicine. That's our metric that'll give us some number that we'll feel confident about, and then we just don't actually think about what it means. But also, if you think about readability scores, they only really relate to this component, the prose component of literacy, but there's so many more components to literacy and understanding. How do you navigate through a document? Can you do it online and the internet? Quantitative, we know numeracy is a big problem. And then verbal, obviously how people have, interpersonal communications and kind of some of the behavioral aspects of things there as well. So that's why I like to say health literate communication is a big concept, but plain language, readability, those type of things that really just focus on the words is the small part in that big whole. There's really a lot more to it. So anyhow, that's kind of, with that foundation, let's move or transition into this regulatory trend towards clear communication and kind of view it in that lens of it's, even though a lot of these regulations just talk about the words, it's bigger than that. We have to think about the process. We have to think about, the procedures, kind of the situation that things, that information is conveyed in, kind of the look and the feel of it. It's a lot more than just the words. So showing this trend, now that's kind of the point of this section. Back in over a decade ago, the United Nations called for the development of appropriate action plans to promote health literacy. And that's what happened, actually. The US has its own action plan to promote health literacy that was kind of released the same time that the Plain Writing Act, or around the same time the Plain Writing Act of 2010 was issued. So we're actually about at our 10th anniversary. October 13th is the 10th anniversary of the Plain Writing Act of 2010. But outside of the US, we have Scotland, Germany, Portugal, Australia, New Zealand, Austria. China was actually the first country to mention health literacy and kind of needing this action plan, but they just didn't get to it before we did. And then Canada, Netherlands, Singapore, Ireland, they're all working towards creating this action plan to, that focuses on, clear health communication that can really promote better health. So there's a lot of policy statements if you're looking for them out there. And there are a lot of federal government agencies that also promote health literacy. So CDC, for example, they have an action plan to improve health literacy, and they have a nice, lengthy website that focuses on health literacy. But you can see their goals are to develop and disseminate health and safety information that is accurate, accessible, and actionable. Integrate clear communication and health literacy in public health planning, funding, policy, development, research, evaluation. So you can see, we have this, one of these major funders of a lot of studies anyway, supports this. So that's great. Some, clinical regulations also support this. And then I'll move into some of the other stuff later for research. But for example, the conditions of participation for home health care, for example. So the conditions of participation in the clinical world are, basically, it's not really a contract, but they're requirements that you have to meet if you're a healthcare provider or health system in order to get reimbursed by Medicare or Medicaid. So they require a patient rights notice that includes patient's right to actively participate, to develop and update their plan of care, to discharge and transfer plans. This notice must be written in a language and manner that patients can understand. So we see, even though you don't see a lot of the term health literacy, you always see this kind of phrase or some version of it that says, patients can understand, or in a language and manner that facilitates understanding, something to that effect. Again, more from a hospital system conditions of participation. This is one of my favorite quotes. This is from the State Operations Manual. Informed consent requires that a patient have a full understanding of that to which he or she has consented. An authorization form from a patient who does not understand what he or she is consenting to is not informed consent. We know that that's true from our compliance standpoint, because of IRBs, and, we've been thinking about all of these, these past indiscretions, research indiscretions over the decades. But it's nice to see the similar patterns in the clinical world as well. So this is nothing new to our researchers who are clinicians. And then again, another one of my favorite quotes from the Joint Commission, and not a new quote. This is from 2007. And I love it because it's bashing my own lawyerly kind. But informed consent forms that are written by lawyers for lawyers do not increase the knowledge of those who, with their signature, are committing to allow the performance of treatments and procedures that may be associated with significant risks. The typical informed consent form is unreadable for any level of reader. And so notice, this was primarily, this is focused on clinical, and you're still getting that. Now translate that into the research world where we have all of these requirements and the fact that this is not even care, this is research. And you can see how it gets much more difficult. State-based laws, the California Consumer Privacy Act focuses in on understanding and, kind of conveying, privacy information. Oregon's Health Decisions Act actually has this quote here, which I put in a recent article that I quoted here. Oregon updated its advance directive laws to make its state authorized advance directive more patient friendly. In doing so, the Oregon statute required the committee creating the form to, this is the part of the statute, to use plain language such as tube feeding and life support instead of medical jargon. So we're seeing this trend of even in the state level and kind of getting more to that micro level of requiring, of understanding that people just don't understand your medical terms. So get and use terms that people do understand. Even in the litigation aspect, this, for example, this Wells versus Kleber in the Louisiana Department of Health was an action that was filed by a number of similarly situated people who were denied Medicaid, and they were too difficult to understand. And so this lawsuit ensued and a settlement happened. And so this is called the Wells settlement. But it requires the Louisiana Department of Health to describe the specific reasons for denial in plain language and in sufficient detail to know the denial rationale. And then it defines plain language as language that the intended audience can readily understand and use because the language is concise, well organized, and follows best practices of plain language writing. So we're seeing in policies and regulations and litigation settlements, we're seeing this trend towards thinking about clear communication, in the clinical world for sure. But we're also getting that, of course, in the research world and internationally. So general data protection regulation, for example, which, I'm sure a lot of you have had training on this back when it started in 2018. But again, some really great quotes about consent from a GDPR perspective. So the consent must be in clear and plain language for the given individual. And again, I love this quote: when seeking consent, org should ensure that they use clear and plain language in all cases. This means a message should be easily understandable for the average person and not for lawyers. I love that. Orgs cannot use long, illegible privacy policies or statements full of jargon. And then what's really great about this working party interpretation here is they also focus on children because they know children use online services. So given that children merit specific protection, any information and communication or processing is addressed to a child should be in such a clear and plain language that the child can easily understand. So that's fantastic to think about your specific audience. But kind of transitioning more to the research world, the EU's lay summary requirement for clinical trials, has led to a lot of progress for clear communication, of clinical research. There's Canada has issued, kind of writing the lay summary basics, posters. We have lay summary summits. So there's a lot that can come from regulations or policy statements that require something to be clear. So there's this trickle down effect, to use a bad analogy to trickle down economics, that if we start at this, at this policy and regulation level, it kind of trickles down to everybody else. So I was co-chair of this health literacy and clinical research work group at the Multi-Regional Clinical Trials Center at Brigham Young Women's Hospital in Harvard. But it was a group of 50 or so folks from all points of the clinical research spectrum. And we put together this website, and we're actually in the process of always constantly evolving because as we learn, we add more things to the website. But, if you're thinking about how can we, or I, in your individual capacity, help integrate health literacy into clinical research, that's what we really tried to do with this website is try to talk about how to weave this into the various parts of the trial life cycle, from recruitment to retention to consent, of course, to lay summary. And so by all means, feel free to check this out. It's free. We've got some guides I'm working on. There's a consent guide that's on there now. And I'm continually working on that, of course, but as we learn more. But this is a good resource to get you started. So let's move into the revised common rule and participant understanding. So because of all of that understanding of, how bad informed consent was. That was in the clinical world, and we also knew that, of course, in the research world. That kind of led to this transition that eventually resulted in the revised common rule. But even think about the Beecher report back in 1966. The reality is that informed consent is often exceedingly difficult or impossible to obtain in any complete sense. The difficulties inherent in this complex situation are no excuse for giving up the effort. Informed consent is a goal toward which we strive. But unfortunately, I think for a number of years there, we just it was more of a protecting the institution rather than informing the participant. And so, again, that led to a lot of the changes, at least from a consent perspective. So some problems with consent under the common rule. So from the Secretary's Advisory Committee on Human Research Participation, which I'm just going to call SACHARP, they in their guidance, they mentioned this. The process of writing consent forms and obtaining consent had become stagnant and overburdened with competing purposes, with most clinical consent forms following the order of the elements of consent as presented in the regulations. And if you've been in the compliance world, in the research arena for a while, like, yeah, of course we would do that. That might seem normal to you, but yet you're thinking again of that from the compliance perspective. Well, the regulations say 1 through 15, so I've got to follow that. But you don't have to follow it in that order. The problem is we are just not risk takers. We don't, and so we put compliance ahead of comprehension. And then from an earlier version, from the notice of proposed rulemaking for human subjects research, which is the kind of led to the common rule, we have this: consent forms have evolved to protect institutions rather than to provide potential research subjects with some of the most important pieces of information that a person would need in order to make an informed decision about whether to enroll in a study. And so this is what I often say, that's the reason we have to deal with this now, because of our past, kind of complacency of protecting ourselves instead of really doing what we're supposed to be doing with informed consent, which is focusing on the participant. So that's where I say IRBs, compliance professionals like us, we are really patient advocates for research participants. So in the clinical world, we have patient advocates that help people, patient navigators. That's really what we are as compliance professionals. We're not there just to protect the institution. We're there to really, help navigate or, a research participant through this process. And so the question becomes, can we advance participant understanding through regulations and oversight? And that's why we have the rule of law in the first place for thousands of years, is we know that we can. It doesn't always work as well as we would like, but we know that when we start from this policy or regulation level, that it does filter down throughout the system over time. It doesn't happen right away. Like, you can't flip the switch from January 18th, 2019 to January 19th when the revised common rule took effect, and then say, okay, everything's going to be different. It's going to take time, to kind of assimilate that. So the revised common rule. So we could quote the language, and here is the language, by the way. But the focus is we've got to think about the content, the organization, the presentation. It all needs to be clear and understandable. You probably went to many trainings about that now. And again, the point of it, I think, is more important than the actual language, but it's to facilitate a participant's decision about whether to participate in the research. So what does that look like? Does that involve e-consent? Does that involve video? Does that involve words? Then kind of juxtapose that with, the practicalities of being able to create a video, for example, for every single study. It's almost impossible. But yet there are some lower cost ways of doing some of those things nowadays. And then the big thing that I'm sure you went to many, many sessions on over the last couple of years, and I know it's something I think about probably, maybe not every day, that would be a little sick and twisted, but probably at least at, a good hour or so every week is that consent must begin with key information. And what does that mean? So again, here's the regulation. Informed consent must begin with a concise and focused presentation of the key information that is most likely to assist a prospective subject. In understanding the reasons why one might or might not want to participate in the research. So that's probably something that you've read many times, but kind of you start to break that down a little bit. Why might somebody want to participate, or why might they not want to participate? We tend to kind of, think of anecdotes, but it often, requires some focus group specific to the study, I think, in order to do it well. So what needs to be in the beginning? So of course you can probably say this is what needs to be in the beginning, because the preamble to the revised common rule says these 5 things. Consent is for research and it's voluntary, purpose, duration, and procedures, reasonably foreseeable risks or discomforts, alternatives, benefits. So you're thinking, well, that's what's said in the common rule, so that's what we're going to do. Well, I like to think back to that one quote as like, previously, the consents just followed the order of things listed in the common rule. And so by listing things here, even in the preamble, even though the preamble is not the binding part of the common rule, it kind of forces people to do those things. And I think that's wrong. And SACRP kind of agrees with that. SACRP recognizes that the elements of consent listed in the preamble may or may not be sufficient to satisfy the requirement of providing key information depending on the study. So it's not just here's the easy way out. You've got to think about this. There needs to be flexibility to include other elements of consent or even additional information that is not a required element of consent, if it would aid understanding. And there should be flexibility to not include one of those 5 elements. Now the problem is, and I'm not naming names or showing screenshots, but if you go to various IRB websites or research-focused websites, they tend to have graphics that talk about those 5 things in the preamble. But yet that is not, it makes it seem like, especially to researchers who don't think about this as much as we all do, is, I've got to have these 5 things and I'm done, when it's more than that. So how do you know if something is understandable? So the rule says this: the information that is given to the subject or legally authorized representative shall be in language understandable to the subject or legally authorized representative. You're like, so what does that mean? But you can see, based on some of the clinical rules that we just went through, the regulations and policy, that's very common language, language understandable to the patient, but now this is the subject. And then again, so what would a reasonable person would want to have in order to make an informed decision? So that's what we're thinking about when you think about, what needs to be in there. But what is a reasonable person? Hello, it's you, it's me. We all think we're reasonable. I don't think anybody on earth thinks that they're unreasonable. I mean, I'm sure there are some that are honest with themselves and say, yeah, I'm probably unreasonable. But most people who are unreasonable don't know it. But the reasonable person, it's a standard that's been in the law for a long time. So I am very comfortable with the reasonable person standard. I kind of get the gist of it. SACRP mentions this: the reasonable person concept recognizes that it's impossible for researchers to determine what information every individual participant would consider helpful in deciding whether or not to participate. Instead, it asks researchers to include what reasonable people in the same or similar circumstances would want or need to know. And so from a legal perspective, I'm like, yeah, this had to be the standard, because there's always going to be people at the margins, who want something different than the masses. But so that's my legal perspectives. But from my health literacy perspective, I care about the individual. I want all the individuals to be able to understand things. And so that's hard to do, of course, without thinking about the individual and taking the individual's, kind of own personal needs into account. And so that's why I say, kind of this one standard way of doing things is not going to work. You're going to need more than just words. It's this process of consent. It's how do you train up, the researchers and, the research staff to appropriately get informed consent in a health literate way. But of course, obviously we need the consent to be clear as well. Otherwise it's really going to be difficult, especially when people go and maybe talk about this with their family or their loved ones or their caregivers or whomever. So really involving the study population, if you think about, well, I don't even know what a reasonable person in my study would want, that's where, involving the study population is vital. And it's actually encouraged. Nobody really talks about this part of the preamble. I think because we're scared. We're like, we can't afford all the time to have this individual assessment that is specific to a study. Well, that may be true for, pilot studies or investigator-initiated studies to some extent. But for the big studies, the funded studies, the ones where you're going for the gold, you should be having this. So what I think this means, let me go back, is it doesn't necessarily need to be a formal user testing or focus groups that you might do if you have just, tons of money where you can bring in somebody else who can do that for you. But involving your study population from the start, this whole patient, centered research where they're part of, community researchers are part of the team, and you can, talk about this and you value what they have to say, especially when it comes to, how do you communicate the information that can be essential to you. And it doesn't have to be hard. I mean, in the health literacy world, when we look at documents, we often do user testing and focus groups, either formally or kind of on a dime informally. It all helps. It's better than nothing. There's some research, which I probably should have cited, but I just am thinking about this off the top of my head, that suggests that if you have five or six people in a focus group or in user testing session, it catches about 85% of the errors. So if you could just have a group of, half a dozen, for example, that hit your study population, and run the communication aspects of that through them, you're going to catch a lot of the problems. And again, so you're going to hit that reasonable person better than what we're doing now. So again, so what else do we know? Well, clarity matters, not length, because we've added with the revised common rule a couple of extra requirements, or up to 3 extra requirements, right? So, and then one mandated requirement. So we're really talking about up to 18 things. So it's really all about how can we break this down in order to create understanding, even though we know it might be lengthier. And there's ways of doing that by chunking and checking and thinking of it less like one legal document and more like training, to get to this end goal. So there's a lot of ways, but flexibility, of course, and creativity are encouraged. So here's some quotes from SACRP again. There's, from a key information perspective, there's great variability in the choice and presentation of key information. But again, so what I really, again, love about some of the guidance from SACRP is that they get more practical. It's not just about what we would think about when we think about risks. Well, the risk is you might have a perforated bowel if you do this or something like that. But instead, they focus on impact on your life by being in the study is certain, but benefits and harms are not. So focusing on what the impact is. Hey, you're going to have to get in your car, drive downtown, find parking, do that 20 times over the course of 2 months. That would be very impactful. I don't know if I'd want to do that versus, something where I go in once or have phone calls, or something like that. So how does health literacy play a role in aiding this patient participant understanding? Well, it helps determine what a reasonable person might understand. We have a lot more research in the health literacy arena now than we did in, the 90s when the common rule went into effect, the first one. So we know a lot more about what, ways of helping convey information. So we can learn from health literacy research and practice to help, facilitate understanding. Some of the things are, using visuals. How do you explain numbers and risks? How do you put in headings and those type of things? And user testing should become a standard practice. It's something we do a lot in health literacy, and not just in the health literacy world, in any of the communication world. focus group testing is huge. So we can learn from that. And then IRBs and compliance professionals are critical to implementing these regulations. So again, that's kind of was your role, or is our role when this was all created because of the past indiscretions, is we need to be the protectors of the participants. And so I think, the revised common rule and all of this trend really helps show that, yeah, we are the gatekeepers. We are the ones that are really caring for the participants. So that kind of gets me excited. So let's sum it up. There's a definite regulatory trend towards health literacy, and I could keep going on with this for another hour, breaking it down from a clinical perspective as well. But we're seeing definitely there is that trend. And there's an ever-changing area. This is an ever-changing area that will continue to grow as institutions focus more on this, and there's more research. There's already in the last, year and a half been a lot more that I've learned, and I know we'll continue to learn over the course of the next decade or so. And use these regulations as an opportunity to better connect, not just comply. So again, remember the motto, connecting while complying. And so with that, I will end my talk, and I look forward to hearing you all, or hearing questions from you all on, after this presentation. Thank you.